We'll be starting. Welcome, everybody. I have our speakers and moderators already online, and there is almost close to 200 registrants for this symposium and webinars, and they will join. It's really a pleasure and honor to have today with us Dr. Arif Ahmed. Dr. Arif Ahmed, currently he's the Director of Robotic Surgery Center of Excellence and Director of Bariatric Surgery Center of Excellence, Mother Northwell Health, Port Jefferson, New York, USA. He has started his career in India, then he moved to USA. He did his medical school and postgraduate training in India. Then he moved also to USA. 94, moved to United States, where he completed his clinical fellowship in surgical nutrition and metabolic care at Harvard Medical School. Then he's going to continue his career and fellowship in minimal invasive surgery at University of Virginia. He's also joined Stony Brook University Hospital, and he established his minimal invasive and bariatric surgery there, and he started or did the first laparoscopic bypass in 2004. He continued his career in the United States and established a lot of achievement in his work, including whether in bariatric surgery or robotic surgery. And currently he's practicing in Mother Northwell, Port Jefferson, New York Hospital. It's a pleasure to have you, Arif, with us in Saudi Society of Bariatric Surgery. And we're always glad to have you, not only this webinar, but also in our future symposium and annual meeting. And it's a pleasure to present today our two moderators, Dr. Muhammad Abu Khater, who is currently consultant bariatric and metabolic surgery. He's the head of minimal invasive and bariatric surgery at King Fahd Medical City. Welcome, Muhammad, with us. And then we have thank you. We have Dr. Abdullah Al-Ghamdi, who is a consultant and bariatric surgeon, and he's currently the Director of Bariatric Program at Johns Hopkins Aramco Healthcare Center in Eastern Province. Welcome, Abdullah.
Thank you, Dr. Fine.
Currently, we will leave Dr. Arif and ask him to continue to start his presentation. And at the end of the presentation, for the audience, please, you will have a lot of options down there. You can throw your question and answer from now on. You can also preferably put it in answer and question, so it will be easy to answer. You can chat also, but mostly better in question and answer. You can also raise your hand, and the moderator will take your question. They will raise your question in your behalf if you put it as a question and answer, and they allow you to talk. They will give you the mic to talk during the presentation, but after the presentation, during the discussion. Dr. Arif, please start.
Good. Thank you. Can you see me on the screen? Can you see the screen as well as myself?
We can see you, but share your screen, please.
Okay, we'll share the screen. Now, do you see it?
Now we see the screen, yes.
Okay, excellent. Okay, so thank you, Dr. Al-Qahtani, for giving me the opportunity to present, for inviting me to present, and to the Society of Saudi Arabian Society of Metabolic and Bariatric Surgery for giving us the opportunity to present my thoughts and to share my thoughts, really, with a lot of people around the world. So good afternoon to the people in the US, and evening, and for the people in the UK and in Saudi Arabia and other countries that are participating in this. I wanted to share my journey, from analog surgery to digital intelligence surgery, which is, I think, what we are seeing, as we're seeing this evolve. So my career began, can we go to the, my career in surgery is, I came out of medical school in 1983. So we were seeing all open surgery there. And then I worked in England, in Scotland and Edinburgh, and then, in London for about 5 years. And we did mainly open surgery at that time. There was really no laparoscopic surgery. And then when I started in the US, we started doing more and more laparoscopic surgeries. And I realized that this is where things are headed. I'm seeing a similar, so I have, the unique position of being completely trained in open surgery in India and in England, and then in laparoscopic surgery in the US initially. Those were the early days of laparoscopic surgery, where we did the first laparoscopic gastric bypass in about 2000. That's about 23 years ago. And then we proceeded to okay, so then we proceeded, to proceed with robotic surgery, and I started doing robotic surgery in 2011. I did my first robotic operation. It was actually a Roux-en-Y gastric bypass, believe it or not, because at that time we thought that the robot is only good for that. But you already have an introduction about my. So the Northwell system is a big health system. If you see how robotic surgery has grown within New York, in 2016, we had 16 Da Vinci systems in New York with the Northwell Health had 16 robotic systems. And now in 2022, they had 50, and another 35 are now being supplied just to the Northwell system. So the Northwell system will now have 85 robots, within the next few months, because the agreement has already been reached. And Northwell is a big system. It has 80,000 employees, which is the largest private employer in New York State. So myself, we are in private practice. We have 4 minimally invasive trained surgeons, and we consider ourselves to be in private practice with academics, because we have a fellowship that we also run, and we teach fellows. Every year we have a fellow that graduates from our program. We're an extremely busy practice, 850 bariatric cases, additionally another 400 minimally invasive surgery cases. And, we have completed more than 4,200 robotic procedures. I'm not talking about the entire Northwell system. I'm talking about my own practice. With my personal cases being about 3,300 robotic cases. I was told by Intuitive that that's the largest experience in the world. So I feel like I'm in a position to share that, with the people who have logged on to here. And we do about 5 to 6, sometimes 7 or 8 robotic cases a day, 4 days a week. And so it's extremely busy. So one of the questions I wanted to address, because I know various people are at different stages of their evolution into robotic surgery from laparoscopic surgery. So one of the things I wanted to address is, why would we want to do robotic surgery? It takes longer, Sometimes in the beginning, this is what we were thinking, at least, that it takes us longer. We were already doing 7 laparoscopic cases a day. Why would we want to change to robotic? And we thought that it takes a long time to set up and dock the robot. And we only thought that it was useful for complex cases. We also thought that it costs more. And we also felt that we had already perfected the laparoscopic technique, and we had spent all these years learning how to do it laparoscopic. And why would we go to something else where we'd have to start again from scratch? And we felt like, we're already ahead of the game, and now we don't want to start at the bottom again. At that point, I had done, a lot of laparoscopic cases, more than 2,000 laparoscopic sleeves at the time, that I started making a full move into. This was more in 2018, late 2018, where I became completely robotic, or almost completely robotic. At that time, we had done about 2,000 sleeves laparoscopically with 4 leaks, 0 transfusions. Every time I tried to do a case robotically, my team was, why are we doing this? But you see that picture on the right of the screen? That is exactly where we were. We had a wheel that couldn't move, and somebody was offering us real wheels, and we said, no, we are too busy. We kept on moving. That's the way we felt, because we realized that it doesn't really take longer currently. The setup and docking currently for us doesn't take more than a few minutes, maybe 5 minutes at most, maybe 6 sometimes, And it's not only useful for complex cases, it's actually useful for simple cases as well. And it actually does not cost us more. And I'll show you why. And we feel that although we had perfected the laparoscopic technique, we have achieved a lot more advancement in our ability to do things now that we've embraced the robotic technology. So the question was, why would we change? And one of the reasons were, firstly, the reasons we changed is because patients with high BMI, we found the access was physically demanding. The angles of dissection were much more difficult. You couldn't really get the angle exactly where you wanted to because we were using straight instruments. The instruments could not angulate at the tip. So it's an inherent disadvantage of the instrument itself. Also, we always felt the potential danger near the splenic hilum. Patients with narrow costal margin and the splenic hilum is high up, and you can't really access it with a straight stick, with a straight instrument. Also wanted to have my best assistant, So my partner, one of my partners who's worked with me for about 12 years, Dr. Agarwala, I always wanted him when I was going to do a case that was difficult. And because, we understood each other, we understood what was needed at what time, when we are doing what, and I felt very dependent on having good quality assistance when I was doing things laparoscopically. And the ability to not deal with higher BMIs had its economic implications. Revisional bariatric surgery was particularly more challenging in laparoscopic cases, And in the interest of time, I'm going to have to move on a little bit faster. But you see, when you have a patient like this, and we do have a significant number, more and more patients are coming like this in the United States, We, in the beginning, were not having patients like this as much as we're getting now in our practice. And some of it is because we're taking them on. But when you have a patient like this, when you're doing it laparoscopically, most of the force that you use on the instrument is spent in fighting the torque of the abdominal wall, because the abdominal wall is so thick that you're going to spend your torque. When you spend that force in fighting the instrument, you cannot get sensitivity and precision at the tip of the instrument. And that is where the problem is. And we realized that no matter how good we got with laparoscopic surgery, we were limited with the inherent limitation of non-computerized equipment. So we were limited. So we realized that the electric light, did not come from the continuous improvement of candles. And this is exactly where we felt we were. And I'm talking about the first thoughts about this in 2011, but my fully embracing the technology of robotic surgery and becoming a totally immersed robotic surgeon, in 2018. So it's very similar to, what you have, the open, you see how we had the typewriter and now we have the word processor, which can do a lot more. So how is computer-assisted surgery improving safety and outcomes? And here we have a similar analogy. You see on the left, you have open surgery, and then you have laparoscopic surgery in the middle. And then on the right, you can see with all the new technologies we have, see now when I'm driving my car now, it tells me ahead of time that there's a pothole in the road at so many points away, and then it tells me how to get there and how to avoid it. So it's really something that you cannot get without the assistance of computerized technology. This is one of the things I was talking about. See, this costal margin is really high. See where this vessel sealer is coming in? The angle at which it can come in is impossible with the laparoscope because the tip is not going to turn or angulate, at the joint, the wrist joint that you have there. So how are we doing these cases laparoscopically? Well, when we're doing this, we're pulling the tissue into the instrument, but really, you want to pull the instrument into the tissue rather than the other way around. So also when you have fused tissue planes, like in this case, this patient had a lap band before, and we can actually see the planes so much better. Actually, you can actually do the dissection of the planes with the view of the 3D anatomy and the precision that you can get with your instrumentation at the top. So this is also the angulation, proper angulation in higher BMI patients with the intelligent stapling. So when the port site of entry is really high and you're trying to come down onto the tissue, you're going to not be able to work with a straight stick. You need to have come in and then angulate up. And that's something that you cannot do without the help of wristed instruments. And then, of course, these instruments, they have a lot of technological advance in terms of, it monitors 1,000 measurements per second and monitors compression before it applies it. And therefore, it is an advancement in robotic stapling technology as well. The other advantage that I found was that you're assisting yourself. You don't have to, wherever you move your head, you don't have to move your eyes and your head and ask somebody else to move it for you or ask somebody to hold it for you. Everything, you're controlling the camera, you're controlling your eyes, you're controlling the other instrument. And if you have another assistant, then they can do dynamic assistance, which means they can move while you're moving in a certain way. So so you're controlling all four arms, and therefore you're not dependent on the assistant anymore. You see? And you can get exactly what you want to achieve. And this is why it's so satisfying. And of course, there are ergonomic advantages as well. So as we all know, when you're trying to do things laparoscopically, you really have to bend your arm and bend your wrist in a certain way and push force in a certain angle. And this really affects, there have been multiple studies to show how it affects surgeons' lives and working lives, because there's a lot more musculoskeletal problems, injuries in laparoscopic surgeons than in any other field of surgery before, other than, laparoscopic surgery. Now that we see that with the robot takes the force and we just have to work on it, The other biggest advantage that I feel is if you're having a new partner come on, or if you're teaching somebody how to do it, you have the console, you have the teaching console. You don't have to ask your assistant to come over to the other side, so if you're teaching somebody and he's not being able to do it exactly how it should be done, you don't have to tell him to come over the table. I call that the walk of shame. You don't have to make him do the walk of shame. You can just take over the instrument from the co-console, which is the console sitting right there. You see the two surgeons there. You can take any instrument you want. You can leave any instrument you want. And therefore, this really helps with patient safety and ability to teach. Here we are doing, that's the vagus that you just saw there. We are pulling the esophagus down. We're doing a hiatal hernia repair. They're passing the instrument, they're passing the needle through that thing. But you can see I'm using the needle holder, the vessel sealer as a needle holder. I call that the Swiss Army knife, because you can use it for various complex things. But and it actually allowed us to start a fellowship, because we would not otherwise be comfortable, letting the fellow do stuff from the other side unless we had that ability to take over when we wanted, which is the great safety mechanism built into the robot. So in conclusion, robotics is an equalizer across complexities. High BMI patients, revisional surgery, if they've had prior surgery, then there'll be a lot more scarring, etc. But not only would that help, in cases of robotic, but also the port positions. Your port position can be further away from the site of surgery because of the longer instrumentation and the ability to angulate it better, especially when you're doing concomitant surgery. So when we're doing, say, a gallbladder with a Roux-en-Y gastric bypass, we don't have to add any additional instruments. We can just work on the same instruments and be able to do it, things like that. So now when I get a patient with a BMI of 83, and if the port has already been put in and I'm just sitting at the console, I'm sitting at the computer console, I cannot tell if the patient has a BMI of 43 or 83, because it makes no difference. Inside, they all look exactly the same, and the ability to do it is exactly the same. So this is something that was unthinkable at the time that I was first beginning to look at robotic surgery. The other thing is the future. We are moving from analog to digital surgery. And what is intelligent surgery? That's where we are moving. Just like you can see in the cards, they give you an idea of what's ahead and what's going on. We're going to have the same kind of thing, same kind of systems within the the Da Vinci intuitive system that we have. And this is founded on the fact that, a computer, when you use a regular instrument, it doesn't collect any data for you. Your data stays in your mind. When you use a robotic instrument, it's actually collecting the data of every piece of information is going into a system that is collecting that data and using that data to get better outcomes. That is impossible with regular instruments. Laparoscopic instruments not connected to computers, regular instruments, they cannot do those things, So this is the data that we have now is founded on 20 years of experience with digital surgery. More than 10 million procedures have been performed, and 60,000 Da Vinci surgeons have been trained. And all that data has been used to form this multifaceted loop, which is called the multifaceted solution, where you take the data, you take the learning, and you form this virtuous loop where data results in better outcomes, and better outcomes and outcomes then feed into giving you better data. And then this is then integrated to form an integrated network. So see, this is where computer surgery is very different from, and we are already doing this. We're seeing these effects. In the past, outcome gave you the data, but now the data is giving you better outcomes. So this has changed. So you see, you have high quality interconnected data that you can automatically collect. It gives you insight, and then it allows you to get to the correct action. And I'm going to show you this in various areas. Let's start with preoperative planning. So before you're doing the case, you can feed the MRI and the CT scan and get 3D modeling by this thing called IRIS. Okay, I think I have some slides on IRIS later. Okay, so I'm going to do that in a minute, but I'm going to just show you that you can use it in preoperative planning, intraoperative guidance, and postoperative analysis. So let's start with preoperative planning. Even before the patient arrives to the operating room, you can actually pull this MRI, as you can see here, and you can get it from the EMR, and then get a 3D model of so this is used for the kidney, for example. And then that model can be shown on your screen. And this is in the future. We already have this. This is IRIS, this can be on your screen, on your console when you're working. So that not only does it assist with patient education and communication of your findings, but it creates a mixed reality environment where this is actually on your console and you can work on it while you're operating, creating almost like a mixed reality environment in preoperative planning. You can also use this for helping people see. This is exactly what you see here on this picture. Here is the 3D model with the formation there. So this is what we can do with IRIS. And then
I think of data as being all around a dark room. And the question is, how do you illuminate the data in some natural way to give you insight? How do we make that data discoverable and actionable?
Okay, so let me just introduce now. We also are getting the Intuitive Hub. We've just been, we were supposed to be the first hospital in the Northwell system. I don't know if we were the first hospital in New York State. I believe we were, right? To get the Intuitive Hub. I'm not exactly sure, but in any event, we were supposed to get that started in the last month. But the Intuitive Hub has really, allowed us to do a lot of different things that we could not previously do. So the Intuitive Hub, what it does, it allows you to share data. Share your screen, with somebody like a telementor. Almost like he's present with you at the same time. So I could be sitting in my office and one of my partners could be operating, or I could be sitting at home. I could even be at the beach and one of my partners could be operating, and I could share the screen with me through the Intuitive Hub. And I could get a lot more information from that. Also, I could get, let's go back to the Intuitive Hub. That's intraoperative planning. So let's go to the preoperative planning. With the Intuitive Hub, you could see what you've done in the past on different situations, and you could use that and I have another slide to explain that to you. Then we have advances in intraoperative guidance. Intraoperative guidance currently is not intelligent, but they're working towards making it more and more intelligent. But you already have certain things, like you have the Firefly technology, for example, which allows us to get better imaging of things that we are working on. But the data, so for example, look at this one here. This is the common bile duct here, you can see at the bottom. On the right, the screen I wanted to show you, you've all seen the common bile duct and the cystic duct lighting up with Firefly. But what I wanted to show you is that you see that on the right of the screen is right here, this is an accessory duct of Lushka, that if we had not been able to see this, we would be damaging this, and that would result in, as we were burning in this area, and that could result in a leak. Now that we can see it so clearly, we can avoid it. So that's an example of intraoperative guidance.
This has been around for a while. Like I said,
yes, and then you have, we also have the 3D modeling, which is used in the ION technology, which is a shape sensing technology, which allows the instrument, the endoscope, to actually know which direction to move. Just like you see when you use your Roomba or you use your robot to clean your room, it knows whether there's a door and it turns around. In a similar kind of a thing, the technology is advancing where it tells you where it needs to turn left or where it needs to turn right, because it's using that kind of robotic technology to advance the scope. So this is augmented reality that's enabling you to do this. Also it gives you better feedback on the instrumentation. And with the Intuitive Hub, like I was saying, it automatically records the procedure for me I could download it on my phone. I can actually see which instrument was used, whether it was used by my surgeon or by myself, for how many minutes, which different instruments were used. I can then share the whole video automatically with my colleagues. I can also watch multiple operating rooms at the same time, sitting in one spot. I can, through the Intuitive Hub. And I can also, in future, what we can do is we can integrate it with the EMR so that it's automatically downloading the entire operation on the EMR. This is what they're working on. It's not available yet, the integration with the EMR. So the Intuitive Hub is really a big advance that we can now see. It also tells you which of the different, in the interest of time, I'll have to go a little bit faster. And then it gives you post-operative analysis and guidance. It allows you to analyze every movement that was made during the procedure. So this is on my phone. I already have this ability, where it can show me who was using the instrument, which surgeon was using the primary surgeon. This is the assistant. They're sitting on the console, as you can see. And arm 1 was used for how many minutes? At this particular time, what was being done? Can we play this again? So you can see how it'll actually show you at a certain time who was using which arm, as you can see this. Which surgeon was using which arm at what time? This went over. Who was using arm 2? Who was controlling arm 3? And what were they doing with it? This is video integrated over timeline view. We already have this, right? And then you can see the insights that can be used are now being used for the super technology, that is SUPR. What this is used is to improve performance, because it measures how many times you moved your hand, in how many movements were purposeful and how many were not purposeful. The top line here shows the inexperienced operator doing a procedure, and the bottom line shows the experienced operator doing the same task of the procedure. And it then helps you to understand how many unnecessary movements you made, how many movements were not precise, and it can help you. So it's very good for training and for learning, and even for people who are already trained, to make them better, because they can analyze their own movements. This is something you could never do with a laparoscope or in open surgery, because it's not being able to collect the data to tell you what is going on. See, for example, on the top one here in the skills application, in this, this is showing you the top performer video is on the right and your video is on the left. And it shows you as you move, as you move, it shows you how many movements were made. You can see how many endowrist manipulations were done, how many on the top line, as you can see, and that helps you to improve your automatically take that thing and improve the thing outside the OR. You could also use this in simulation technology, which you already have, and I think most of you are using it. And then the future is really even more exciting, with where you have this kind of equipment that you can see. This is a single thing. It comes out as a single, vision, and then through that vision capability, there come out two arms that you can actually do the procedures through this. And if this can be done, you can imagine that everything can be done through an endoscope. I'm not saying that Da Vinci has that yet, but what I'm saying is that if you can do it as a single port like this, and you can put all this in an endoscope, then you really can do almost everything endoscopically. On the right, you have the EON technology, which shows, do you have a bigger video of this? Let me see. No, it's the same one I'm showing. And there's no sound, but it basically, it's the shape sensing technology. In the interest of time, I think I will move on from that one, because with the 30 minutes, but just let me see if I can play it a little bit more. This technology, allows you to know where the bronchus is going, and it allows you to get into that area through shape sensing technology. So in conclusion, the best robotic platforms improve outcomes, reduce variability, and support personalized learning, through this integration of data. And I want to show you my own data in this, because I'm just not talking about an opinion, but I wanted to show you my own data. First, if you compare data of older robotic technology, when you compare that with laparoscopic, this is a good paper because it's a multi-system review of multiple observational studies. And on the right here, you can see the odds ratio, and some cases were better robotic, some were better laparoscopic. Our own study in 2015, we compared laparoscopic gastric bypass with robotic gastric bypass, 173 patients in each arm, and we really didn't find any difference. This was my own in 2015. And there are various other authors that have looked at this, but I think in 2023, we are finding differences, so now we've completed 4,000 procedures and 15,000 firings of the shear form stapler. And this is my own data. But if you look at concomitant hiatal hernia repairs, we were comparing robotic sleeves with laparoscopic sleeves from 2016 to, which were laparoscopic 2016. Let's go back to that. Yeah, okay. There's something in the way that's blocking my view. And then there's the Da Vinci sleeves from 2018 when I started doing them also. Compare 1400. And we actually see that the data here shows that there's an improvement in everything: 90-day readmissions, reoperations, blood transfusions, staple line leaks. Everything in my data has actually shown an improvement. You can see the laparoscopic one was yellow and the robotic is blue. Okay, so can we go back to the next? Okay, thank you. So it has impacted efficiency and outcome and volume. It also affects volume. So this is just showing you how we operate. We have 2 rooms. We have a swing room. And as you can see, we can accomplish 6 to 7 cases, robotic cases a day, and still be done by around 5 o'clock, supposed to start at 7:30, but as you can see, we don't often start till 8:05, but yet, okay, go ahead. Next is, it's also improved our volumes, and it's improved so in terms of cost, if you compare cost of a sleeve done laparoscopically and robotically, I've broken down each item, and for us, it really costs the same. In fact, it's a little bit cheaper robotically. If you use, and now, of course, there are 2 aspects of cost. There's direct cost and there's indirect cost, and the total cost. So when you acquire the robot, it will cost money, of course. But once you already have the robot, then the direct costs for each case are actually less with the robot. And we found similar things with other, do we have the bypass, or do we? Yeah, with the bypass, again, you can see that actually cost us less with the bypass. And one of the main reasons was the stapling was not being, was actually costing us less with the robot rather than with the laparoscope. And then when you compare other procedures, like here I compared cholecystectomies in our hospital, robotic, 530 to 910 versus laparoscopic, you can see is a little bit more. So although the initial outlay where you have to buy the robot will cost you money. After that, each time it actually costs less. And then the Intuitive company has come up with various plans where it may not cost. For example, at our hospital, we don't have to necessarily outlay the money up front. And the cost is built into each use. But those are different things that I'm sure in different continents and different countries, different hospitals, they're going to say. But here's my main point, everywhere in life, you have to go where things are going, not where they are. You see, if you try to go where something is, then it'll be too late. You have to go to where you have to look into the future and go into the future. And this is where we are going. I'm sorry, I think I've run over by a few minutes. So if you have
global life expectancy more than doubled. In the future, Intuitive's focus won't only be on extending how long we live, but also on extending how well we live.
So here you see this surgeon
Da Vinci is ready.
Is getting ready to do a lung biopsy followed by a lobectomy. She's going to do all that at one setting. Talk to the family, do all that because of the ability to preoperatively plan, to have more information, to use that, to leverage that information in a manner that can be
In the meantime, here's Dr. Singh.
Good to see you again.
If your biopsy is malignant, we'll take you straight to surgery.
This interconnectedness of, the different things that are being used.
Lung adenocarcinoma, confirmed.
Confirming, Jack-Su's nodule is malignant. OR number 9 is being prepped.
I'd like 3 additions to my case cart: the fluorescence scope, imaging agents, and the microstapler.
Confirmed.
Attention code 7, emergency room, first floor. Attention code 7, emergency room, first floor.
Initiate timeout. The patient is Jack-Su, who is having...
Okay, so I don't want to necessarily keep on going because we don't have that much time, but robotic-assisted bariatric surgery is not only efficient, it can be both time efficient and cost effective, and it can allow us to do things that we weren't able to do before. One of the main messages that I want to give you is when you start adopting robotic surgery, for those of you that are new to it, you need to have a time where you're totally immersed in the robot. You have to master the tool. Once you master the tool, then you'll see it will do wonders for you. And to master the tool, you have to do a minimum of 3 to 5 robotic cases per week. We do about 7 robotic cases each of the operating days that we operate. We operate 4 days a week. And we do about 6-7 robotic cases every single day. So the whole team gets the experience, the ability that it becomes so much easier to do it. But it will allow you to tackle a much wider variety of patients, higher BMIs, revisions, with much more precision, ease, and safety. And then the other very important point is robotic intelligent surgery is here to stay and will continue to get better. So, and that is my main message here, So I'm ready for questions. And I hope that you found this useful. Go ahead.
Thank you, Dr. Atif. This is really a great futuristic view, actually, of robotic surgery. We started actually doing robotic bariatric surgery in 2019, and there are some obstacles that we are facing. Actually, one of the main things is that Intuitive themselves, they are coming through a dealer in the area, like through a vendor. They are not in direct communication with us, so we lack a lot of the support and the educational services that they are providing. This is one of the things. Still, the cost and the OR duration is one of the things that really interfere with the full implementation of robotic. I still do the mix of laparoscopic and robotic, but then I find myself really to just finish the list sometimes is to compare to laparoscopic. And instead of doing robotic, I do it laparoscopic. So that will help to finish the waiting list faster. The challenge is, yes, I can develop myself as an individual surgeon, but you have a team where they have their learning curve, and unless they are a constant team with you all the time, you will not be able to have a well-trained synchronous team. That you will have still the issue with the anesthesia, with the assistant, with the nurses, and all that stuff. Some of the limitations I have is, for example, the in a super obese patients, the ports, the markers, they are the same as the short ports. Yes, you have an extra length inside the abdomen, but you still the thick line, you still have it in the same place in all the ports. The first entry is still an issue, because you still have to use the 5mm laparoscopic camera to go in, and that delay the procedure. So there are certain things related to the robot itself, to the instruments. We are lucky to have the visual sealer, the Sureform 60mm stapler. We are lucky to have that. That really made a big change in the length of the surgery and what kind of procedures that we can do. But we still there. I'm past my 100 case, variety of cases. I do everything actually. And I found robots superior in revision of bariatric surgeries. Like when I have a sleeve and I want to go for a bypass, it's actually a problem with when you find the adhesions, hiatal hernias, and the robots just make it very easy for you, really give you that real ease that you can do the procedure comfortably and mastering everything actually. So yes, we still developing robotic surgery. Our colleagues in robotic and urology and gynae, they are ahead of us. But there are certain areas that really need constant improvement and support. We have only one machine, so we are lucky that machine is not broken. So all the services are using it. We have a committee that somehow organize who can use the OR, but we still have those challenges from now and then.
Yes, so that is, I think in the beginning we had similar challenges, because what I found was once you really totally immerse yourself into it and say, I'm going to do all my cases robotic for a period of 2 months or 3 months, no matter how much I suffer, I'm going to do it, then you realize you get really good at it. And that's the commitment we made. And once we got really good at it, the whole team got better and everything started moving in the right direction. But if you, in the beginning, you give yourself the choice that I can do it laparoscopic or I can do it robotic, because you have to master the tool and it takes time to master the tool. It takes patience to master the tool. It's a new tool. But once your whole team masters it, then you'll find that you'll start seeing the advantages of robotic surgery. In terms of the larger BMI patients, we find using the longer instruments, we don't necessarily, personally, I don't necessarily follow where the black mark is. As long as there's a certain amount inside, the rest of it can be outside. I don't follow the black marks at all. It doesn't really matter. And I think that if you try that, you'll find that you'll be able to use the extra long instruments in the super morbidly obese. That's what we do, and we are working fine with it, In terms of having the vendor, rather than Intuitive, be the people that are training you, that I think, the vendors have to be probably better trained by Intuitive. That is something that Intuitive has to do. But it just came to my mind, if we can train surgeons with telepresence, why can Intuitive not train its vendors with telepresence? And why can Intuitive not be present in Saudi Arabia? You're the biggest, are you the biggest, in Riyadh, the biggest center?
Attention code 4, outside coffee shop, first floor.
So,
Attention code 4.
so I think that if you are a big hospital there, Intuitive, all the people who come and train us here, who train our people, they can be present by telepresence there. I think that those are all things that Intuitive has to deal with. I would say from your point of view, you should tell them that we need your telepresence of the Intuitive people. The same people who train people in the US, they should be able to be telepresent in Saudi Arabia and all the other parts of the world so that they can do the same job by telepresence. And today it is possible. And I think that these things are changing. The future is bright in this manner because more and more we are getting all these telepresence things organized,
I am actually with technology. I believe it is the future for laparoscopy. It is one of the advanced tools that definitely it will help us doing more complex cases, more challenging cases, and eliminating some factors like you are getting older, standing for a long time, and the limitations with the assistant and the team and all that stuff. I believe in it as a technology, but it should be a holistic approach. It's not an individual who can really achieve this. It's a hospital, it's the management, it's the supplies, it's a whole thing. Like it should be a real move toward robotic surgery as a holistic thing, not individuals, not people by themselves. We try to do our best. I'm here in the eastern province of Saudi Arabia. It is actually an area called Dhahran. We have John Hopkins Aramco Hospital is a big hospital, so we have a variety of cases. We have a good hospital, like with all support services, and the management to some extent they are supporting actually. But yeah, I mean, we need to do more volume. We need to do more cases.
Okay, we have a question, Dr. Arif, from the attendees, Dr. Abdurrahman Salim. He will ask the question now.
Yes.
Please, Dr. Abdurrahman, can you unmute and ask your question? Dr. Abdurrahman? Okay, he did not type his question. So we have another question. I think Dr. Abdurrahman is not... okay. We have a question from Dr. Ahmed Salman. He's asking what's the difference between Versus and Da Vinci. This is what I can hear here.
Versus is a different robot, right? It is the CMR. It is the CMR robot. I believe that it's the one that is by Cambridge Medical that is being used in England. Is that the one that is the Versus robot? We in the United States, only FDA approval is only for the Intuitive robot, not for any other robots. So I have no practical experience with them. I have read about them and I have watched videos about them, and I think that they're an open platform rather than a closed platform where you can see everything like a laparoscope. And I believe that they do not have stapling technology. No, none of these have stapling technology yet. And I believe that they're using the laparoscope for it. The most advanced among the other robots so far is the one by Medtronic, where they have done cases with it in various parts of the world. They've done a bypass, I think in one of the South American countries they did it, and also they've done it experimentally in the US, right? Without FDA approval.
Okay, we have another question from, okay, I think Dr. Abdurrahman Salim. He did not, he's unmute. Okay, Dr. Abdurrahman Salim.
Assalamu alaikum. Hi, Dr. Arif.
Yes.
Very nice, informative lecture. Just with this huge experience, I want to ask you regarding your conversion from robotic to laparoscopic.
Yes.
The first question. The second question, did you think this robotic will reduce the complication of bariatric surgery, including leak and bleeding?
So very good questions. And to answer that question, the first point is that why is your question? The first question you said was my conversion from laparoscopic to robotic. Did you mean to say why I moved from laparoscopic to robotic, or what was the question?
The question, the rate and why.
Conversion. Oh, you mean patients that I was doing robotic, I converted into laparoscopic?
That's right, yes.
No, I did none of those. There was no cases that I had to convert from robotic into laparoscopic. Actually, there was one case which happened more recently in the last few months, and that was because we had a problem with the stapler, that we couldn't complete the operation because of the malfunction of the stapler and the equipment. Not just the stapler, the whole equipment was malfunctioning, that particular robot. And so we had to complete that case laparoscopically. But in about 4,000 cases, that's the only one that we've had to convert from robotic to laparoscopic. We've never had to do that, you know. We've managed to always do it robotic. In terms of your second question, which was
complications.
The complications, do you think that it will reduce complications? So when we studied it in 2015, there was no difference in the complication rate between robotic and laparoscopic in our hands, 173 in each arm, as I showed you in the data. But currently, like I showed you with my data, it has reduced in my hands, it has reduced complications. It has each area reduced patient readmission rates, reduced length of stay, reduced, except for the duration of the procedure, everything else is reduced. As I showed you, I can go back to that slide. Let me see if I can get back to it. So here you can see 90-day readmissions, reoperations, blood transfusions were about the same. Staple line leak, when we compared laparoscopic with robotic sleeve, the yellow is laparoscopic, the blue is robotic. So in that period, it has actually, for us, that's what it has done. Now, will it always be able to do this, and why will it do this? And I think that if you can master the tool, then I think it will be able to do it. The reason it would be able to do it is because you can get much more precision, you can see better, especially in revisional cases. You're not fighting, and in higher BMIs, you're not fighting the torque. You're being able to be precise at where you want to work. So I don't know that everyone will get the same, data, but this is what we have found in our data. And it's not a big difference, but there is a difference, And I think as robotic technology advances, the difference will become wider and wider.
Okay, I have a question. I think there's nobody from attendees has a question, so I will just give you my experience. I'm working in King Fahd Medical City in Riyadh, one of the biggest city in Middle East. So we started robotic surgery in 2018. I did around 130 patients until now. I have just because for people who are starting robotic, who did not start any type of robotic surgery, when you go on robotic bariatric surgery, I think it's the future. And I wish I can do all my cases robotic. But I have the similar problem because we are fighting in the room. Not fighting, we have urology people, gynecology people, so we have our term in that room. Anyhow, for my colleague in bariatric surgery, I advise them if they are just starting in robotic, they should not do bypass immediately. They should start with sleeve gastrectomy at the beginning. Why? To get used with, orient themselves in the robotic, and so they can do smoothly sleeve gastrectomy. Then the second stage, they can go on bypass and revision surgery. What do you think, Dr. Arif, in this comment?
Completely, I think. I'm sorry, I'm unmuted. Yes,
yes.
I agree with you completely about that. I think that if you're having to fight for the robot, then it becomes very hard because you don't have to fight for the laparoscope, and you just rather do it laparoscopically. So we never have to fight for the robot because we have access to double rooms. So we call it swing rooms here. So you start one case, and then the other case is ready, and I move from room to room. And sometimes I have 3 rooms, and all 3 have robots. So I think at the minimum, you need to get another robot, or the intuitive has to get it to you, maybe free of cost or at a cost that it doesn't cost you that much. And then once you have access to those 2 robots at the same time, then it will really make life so much easier for you because they'll get ready in one room and you just go to the other room. I think that for the people who are learning, I think that, now we have availability of simulation. You should start with simpler things. I think if you're a bariatric surgeon, then sleeve, yes, definitely. That would be the best way to go, because it's very easy among the technical parts of this operation. Definitely not do a bypass in the beginning. You have to be, the other thing I'm noticing that I think is really worth talking about is that our trainees, those residents who are learning in the robotic places, when they come out, they don't have that much good experience with laparoscopic. And unfortunately, that is the way it is going to be in the future, at least in the US, because more and more people are doing things robotically. It's much easier to do it robotic than to do laparoscopic. Learning laparoscopic takes longer than learning robotic. You can go from open to robotic, but going from open to laparoscopic is much harder, So we are going to find there'll be a whole generation of people in the next maybe 5, 10, 15 years who will be coming out with not able to do it laparoscopic, but they can do it robotic. And this happened with the cars. When we're doing manual, if you go to Europe, they're all many places, there's only manual cars. When I first learned driving in India, I was driving manual. But now when I go to Europe and it's a manual car, I really get trouble. I have trouble driving it because everything is automatic. So the same thing we're going to find when we try to go back to laparoscopic from robotic. But in the beginning, yes, I think we should do the simpler cases, of course.
Great. Dr. Arif, we have one of the attendees. He wants to ask you questions, so we'll try to. Yes. Dr. Muhammad Sarhan.
Hello, assalamu alaikum. Can you hear me?
Walaikum salam. Yes.
Yes. Greetings, warm greetings for you, Dr. Arif, Dr. Qahtani, Dr. Al-Ghamdi, Dr. Abu Khater. Very happy to attend the webinar. Actually, we have benefited a lot from your lecture, Dr. Arif. Here in Egypt, first of all, I'm Dr. Muhammad Sarhan, Professor of Surgery in Cairo University. Here in Egypt, we started our program in the first year. We did 80 cases, but with another system, the Versius system. So actually, it's less mature than the intuitive. It is, we can call it robotic assisted because they are still working on the staplers. So we have to staple like the SI from outside, from the laparoscopic port. And that's the difference. So I have two questions for you, please. The first one is the robotic systems is not still supported by the insurance companies. So the patients have to pay the whole amount. So it's much more expensive than laparoscopic here in Egypt. So number one, how can we do this awareness and persuade the patient with this big difference in order to do the operation robotically or robotic assisted than laparoscopic? This number one. Number two, we have a lot of resistance from surgeons to use the robotic in bariatric surgery. Because it's changed like the change of laparoscopy, and because also it's not done 100% robotically. So we have this very big resistance here in a starting country for robotic surgery like Egypt. Thank you so much, Dr. Arif.
No, thank you for your question, and I'm so happy that this was of assistance to you, this presentation, and that it was of help to you. Now, to answer your first question about the insurance coverage for robotic surgery versus laparoscopic surgery, in New York and in most of the states of the United States of America, it is not a problem to get, because the charge that the surgeon gets paid the same, whether it's done laparoscopic or robotic. And the hospitals usually get paid the same. So the insurance companies don't care how you do it, by and large, because they're not paying extra because you're doing it robotic. They're going to pay the same. And they're not paying the surgeon extra, and they're not paying the hospital anything extra. So they don't care whether it's robotic or laparoscopic. They just say, so we just say that we want to get approval for this procedure done laparoscopically. The way we look at it is the robot is an instrument, like any other instrument, like your harmonic scalpel, like your, other instruments you could use. And what instruments we use, we could choose on our own to use. So we haven't had that problem at all. And I think that as long as your insurance company in Egypt is paying the same, then I don't think they will care, but if they have to pay more, then I think you will find that it's a problem, because you have to then prove that, they will be resistant, because they'll say, now you have to prove that this is necessary, that it is better. And that will never be able to advance your, robotic experience. With reference to, because of the Verseus robot where somebody else is firing the stapler, that is something that I'm against, because if you're going to sit at the console and you're doing the thing robotically and somebody else is firing the stapler in a sleeve, then I think that defeats the whole purpose of you being the surgeon and wanting to do everything, So I'm against that completely. I never use that technique where somebody else is firing the stapler and I'm, the surgeon has to be in charge, has to be doing the dissection, has to be firing the stapler, and has to be able to do exactly how he wants to do it. And that's one of the reasons I wouldn't do any technology or any robot that, the stapler is somebody else and this is something else, I understand if you don't have the option in the beginning, you may want to just get an introduction to robotic technology in that fashion. But that I think is a big limiting factor in adoption.
Thank you, Dr. Arif and Dr. Sarhan, for your question. Now we have a last question from one of the audience, Dr. Fadel Al-Zahrani. His question is your experience that influenced your result, or it was the tool you used? I don't know. This is the question from.
He's actually, we can't allow him to talk. He's actually raising his hand, so we'll see if he will.
Okay, if he's here, he can.
Assalamu alaikum. How are you, Dr. Arif? We've met in Mecca before. Assalamu alaikum, Dr. Abu Khater. كيف حالك, Dr. Ghandi?
Oh, yes.
Yeah.
Nice to
we
see
had
you
the pleasure
again.
of having him in our hospital, and he presented about robotic surgery. So your data is very, very nice, really, and really thank you for the presentation that you gave. But my question is, as with most of laparoscopic surgeon, the learning curve is there and everything is there, and I think I'm not sure really, but whether the robot has helped you to improve your results, since you are an old laparoscopic practitioner, or whether is it the robotic, the robot that actually made your results better. So this is one. Second question is that there is a growing talk now about the stapler, the robotic stapler, and misfires and issues that are growing with a growing concern in the States. So how about your experience in that field? Thank you very much.
Very good. No, thank you. Those are both very relevant questions. So I think the first question is my experience with laparoscopic surgery, because, I've had so many years of experience with it. I was one of the pioneers of laparoscopic Roux-en-Y gastric bypass in at least in Long Island in New York. And so we had a lot of experience with it. We had very good results to start with. As I showed you in my paper that I published in 2015, comparing robotic with laparoscopic, there was no difference in the complication rate. So I think that some of it has to do with with our technical ability and attention to detail and all these other things that are absolutely essential in any good results. I think that there's a marginal improvement, as I showed you in the data, slight improvement, in some of the things like return to the OR or readmission rates, because I definitely think that the tool of robotic surgery, for example, I found this very well demonstrated in the sleeves as well as in the hernias. So in the sleeves, when I was doing them laparoscopically, patients had more nausea and more pain. And one of the reasons was, you can get a much straighter sleeve with much less twisting when you do it robotic, because you can bring the stapler at the correct angle. You cannot do that with the laparoscope because you're pulling the stomach into the stapler. This way, the stomach sits where it is, and you're placing the stapler at the correct angle. You see, so you can get it in. And that results in a slight difference in the degree of twist of the sleeve. And that results in less nausea. You see, so some of it is from the equipment. And I think the equipment is an advancing equipment. So it's only going to get better and better and better. I'm seeing this every day. So that is going to be the future. With reference to the misfirings of the stapler, to be honest, I have seen that as well. We've seen that more recently happening in the last, I would say, 3 or 4 months. I have also seen more misfirings of the stapler and things like that. And some of it has been corrected in the last month or two, where it has not happened. Some of the thing may be something to do with the batch or something to do with the algorithm that they were using. And I think that you're going to continue to get those kind of things in anything that's computerized, that you're going to get where they're going to make adjustments. You see, when they come up with the new advanced computerized cars, then they always tell you, oh, there's a recall on this, and this has to be, this went wrong, and therefore they did, you know, there were problems with attaching the stapler to the robot. We saw that also. And sometimes when we have when we find that it's not attaching, then we change that whole instrument set to use a different one. None of this has been a patient safety concern, however, I must say. Some people think that the bleeding rate is higher with their stapler, but my own opinion is, if you look closely at what is bleeding, and some of these were on, you know, international robotic, Facebook, etc., then you realize that the part that was bleeding had nothing to do with the stapler. You know, it was bleeding either from the mesentery or from a part that was beyond, where there was no staple, or it was where there's just a vessel with no, like, you know, the tip of the stomach right at the top at the G junction area, there's a vessel there. If you find the stapler there, you know, even if you find the white stapler, it's going to bleed because it's only the artery there, you know, there's no tissue of stomach there. So some of that, I think, has to be looked at more closely, in my opinion.
Thank you very much.
Okay. Dr. Abu Khater, just one thing I noticed in the bio of Dr. Arif is being a center of excellence on robotic surgery. But I think that is a great thing, actually, not to have all the services and being as virtually one center and getting it accredited as a robotic center. That must be something really very, very challenging to achieve, and it is a great thing to have.
Yes, thank you.
I think we have, thank you. We have no question, Dr. Arif, from the attendees. But what do you think about the future of robot, not in Da Vinci, in other companies? Do you think what's your opinion in bariatric surgery?
Okay. Yeah, there's just one more thing I wanted to add, you know, with reference to the statement, the word misfiring, where it depends what you mean by misfiring. So we've had times where the stapler has fired and then it has stopped in the middle and cannot proceed. You know, although in the beginning it said that it was an appropriate size. You know, there are other cases where other people have had in the US, they've had, you know, they call it bleeding from the staple line, etc., etc. But misfiring, it depends what you mean by the word misfiring. So
what's going in the discussion nowadays in these ACS communities and also bariatric ASMBS is that there is they started to find holes in the middle of the stable line where there are missed staples, and that's what I meant by it.
No, I have never had that, and I have never seen any video showing that. I don't know where this is, but please send it to me if you see anything, because I have never seen anything like that. There is a missed staple in the middle, or there's a hole in the staple line. Yes, please.
Thank you. Okay. I have to conclude this symposium. First, I would like to thank our moderator, Dr. Abu Khater and Dr. Al-Ghamdi. Thank you so much for your leading this moderations and this symposium. And on top of this, I would like to thank our speakers, Dr. Arif Ahmed. Thank you so much. And welcome to our Saudi Society of Bariatric and Metabolic Surgery. As always, hopefully a guest and partners with us. And we always appreciate the people partnering with our society in the long term and sharing our knowledge, our experience, and all together. Thank you so much for our audience and everybody. And God bless you all and have a good night.
Thank you. It's a pleasure to be able to share my information, and thank you for having me.
Thank you.
Thank you.
Thank you.